Welcome back, everyone. We're going to rush right in to our next session, which will be, I think, fast and furious. We're going to move into a discussion now of some examples of successful clinical scientific government partnerships. We're going to tap into some of our colleagues in Europe and in Canada, and then also talk a little bit about some partnerships going on in the US as examples of how these things come about and what sort of outcomes they can produce. Our first presenter is Dr. Lynn Turner-Stokes. She's the Northwick Park Professor of Rehabilitation Medicine at King's College in London. Dr. Turner-Stokes is internationally renowned for her work on the UK Rehabilitation Outcomes Collaborative, or UKROCS, awesome name, for her efforts to advance evidence-based rehabilitation practice. And, I personally have studied her work very carefully to look for parallels in terms of what might be done here, despite the fact that we're very different healthcare systems. So very much looking forward, Lynn, to your discussion. So welcome.
Thank you very much. I hope I've unmuted.
You're good. You're good.
I'm good. Okay. Thank you very much. Thank you for inviting me. And I'm happy to open this session on successful clinical governance scientific partnerships. Could I have the next slide, please? So in the last 30 years, health systems around the world have introduced activity-based costing and payment models. And case mix design is typically based on diagnosis-related groups, that is DRGs, which, as we all know in rehabilitation, are poor indicators of cost. So in the 1990s, we saw development of costing and payment models for rehabilitation, first off in the US with groups like the Uniform Data Systems on developing function-related groups based on the FIM, and in Australia, similarly, a blended payment model also based on the FIM. And in terms of value for money, both systems use the FIM scores on admission as a proxy for case mix complexity, and FIM scores on discharge as a proxy for the ongoing costs of care. And therefore, they estimate value for money in terms of the FIM gain over the length of stay as being a measure of cost efficiency. Next slide, please. The problem with using the FIM as a basis for case mix is that it generates ordinal data. And so when you graph it out, you get an S-shaped curve with floor and ceiling effects, which you can see there towards the bottom and the top end of the scale. And this model of FIM efficiency, FIM gain over length of stay, really therefore only works in the straight part of the scale. Next slide, please. If you have patients who fall like patient B above the ceiling or like patient C below the floor of the scale, then because of the flattening of the FIM curve, you just won't see the gain and you'll underestimate the gain that occurs there. So we need different measures to capture the full gains and cost efficiency of those patients. So our case mix in the UK started later and learned from these models, and the UKROCS model has evolved based on more direct measures of cost, both of rehabilitation and cost efficiency. Next slide, please. We were founded in 2008. We started off with an NIHR-funded program of applied research, and we developed a national clinical database and registry, which built on the US and Australian models, developing and introducing other tools. And since 2015, we've been funded by NHS England, which is our Department of Health. And we provide to them the commissioning data set for every patient admitted to a specialist rehabilitation, that's a level 1 tertiary centre or a level 2 district centre in England. And we provide data for all of those services, every patient going through. There are about 75 in England, and we now have over 80,000 episodes, which I know is small in US terms, but these are really complex selected patients. So next, and just say, since 2017, we've had registry status. We collect identifiable data in the form of the NHS number. So we can now track patients through from acute care through to rehabilitation and discharge through linkage with other data sets. Next slide, please. So what does the extended data set look like? It collects data on needs, of rehabilitation, the inputs provided to meet those needs, and outcomes, all gathered in routine clinical practice. So for complexity of rehabilitation needs, we have the rehab complexity scale. For the inputs provided to meet those needs, we have the Northwick Park nursing and therapy dependency scales and the care needs assessment. For outcomes, we use the FIM plus FAM, which is an extended version of the FAM, which I'm sure you're all familiar with, and we look at reduction in care needs and costs. Our episode costs are based on a complexity weighted bed day cost based on the rehabilitation complexity scale, and cost efficiency is the time taken to offset the cost of rehabilitation by savings in the cost of ongoing care needs, from which we can extrapolate to lifetime savings. Next slide, please. But if we're going to measure these things, we need to embed measurement into clinical practice, and we need simple practical tools that are useful to clinicians in their everyday decision making. So our first priority was to have a measure for needs and costs. So if we look on the left at the principal determinant of costs, those are the basic self-care and nursing needs that a patient will have wherever they are, the therapy needs, the number of different disciplines, the intensity of input, and any specialist facilities and equipment. We need to know about the medical needs, their medical support environment. Do they need 24-hour emergency care available? Do they need procedures or investigations? And the length of the programme, that is the bed days. And if we know all that about a patient, then we know a lot about the costs of their care. So that's exactly what the rehabilitation complexity scale measures on the right. And you can see the items there that relate to those different things. It scores out of 22, and it predicts reliably about 70% of the variation in costs of rehabilitation. It's simple and quick to score. I score it every morning and every Tuesday morning in my ward round. It takes me about 5 minutes to score all 24 patients on my ward. So we can record it serially over time by recording it every week. So we capture changing needs as the patient progresses through the care needs through the programme, and their care needs tend to reduce and their medical needs tend to reduce as they improve, although their therapy needs often remain the same. And so we can see what the different complexities are. And we now use this for the basis for our complexity weighted bed day tariffs. Could I have next slide, please? But the challenge for very severe disability is that many patients will remain dependent. And nevertheless, reduction of care costs is still important. So if we take just as an example, a patient with severe brain injury admitted for a 4-month programme of specialist rehabilitation. So this is just an example. These are notional figures, but if we take before rehabilitation, had that patient not gone into rehab, but gone into the community, they might have required a care package of 2 live-in carers costing about £2,500 a week. If after rehabilitation we've managed to reduce that to 1 live-in carer, we've halved the cost. So we've got a saving of £1,250 per week or £5,000 a month. So if the cost of the rehabilitation episode was £50,000, which is a lot of money, that cost is offset within 10 months. And that is a powerful argument for providing rehabilitation. But we needed the measures to record this routinely in the course of clinical practice. Next slide, please. So our directly costable measure is, in this sense, is the Northwick Park dependency scale and care needs assessment. It provides a direct assessment of care needs in terms of the number of carers required for each task and the time taken to deliver it. It translates by a computerized algorithm into a number of different outputs, but they include the timetable of care needs in the community, when those care needs happen, how many people are needed at each point. So from that, we can get the care package that's required to meet their needs and its approximate weekly cost. Cost efficiency, as I've said, we measure by time to offset the cost of rehabilitation by savings in the cost of ongoing care. And we can extrapolate that over their lifetime from the annual saving in care costs times the remaining years of life, allowing for reduced life expectancy. Next slide, please. So just as a quick example of a few of the outputs that we've had, our first publication on this data set came in 2016. It was an analysis of over 5,000 patients, including all rehab episodes, so brain injury, spinal cord, progressive conditions. We took those that had complete Northwick Park dependency care needs assessment data and complete FIM plus FAM. And it really doesn't matter what the diagnosis is. Pretty much what you find is the length of stay is broadly 90 days. The cost of the rehabilitation programme around about £40,000. The reduction in care costs about £500 a week, and the time to offset the cost of rehabilitation about 18 months. And I appreciate that's a lot longer in rehabilitation than you'd normally see in the States. But remember, this is a selected group of highly complex patients with highly complex needs, including people, for example, who are emerging from disordered consciousness. Next slide, please. We also analysed by dependency. So if we take, we divided patients into high, medium and low dependency groups, and high dependency defined as those needing 2 carers for most of their care tasks when they come in, medium 1 carer, and low they're moving on to independence. And you can see, looking at the high and low care groups there, that the length of stay was approximately twice as long in the high dependency group as you'd expect. So they cost about twice the amount in the rehabilitation programme. But the mean reduction in care costs was about 6 times the amount, which meant that the time to offset the cost of rehabilitation was only 14 months compared to nearly twice that. So we demonstrated that using our method, the highly dependent patients were the most efficient, whereas if you look at FIM efficiency, it's the medium dependency patients who are the most efficient, and that's just a facet of the S-shaped curve that I talked about earlier. So the point about this is that severely dependent patients in many countries are unlikely to receive rehabilitation if then the system requires them to show a continued change in FIM scores. These changes in care needs all fell below the floor of the FIM, which really didn't change very much in those heavy patients. So it is a powerful argument, but it looks at a different group of patients, and that's why we can manage to provide rehabilitation for that group. Next slide, please. In terms of estimated lifetime savings, the US Life Expectancy Project computes percentage of normal life expectancy in 4 groups based on their FIM, eating and walking scores at discharge. And we adjusted for UK mortality statistics because patients live a bit longer in the UK. And the net lifetime savings were calculated as savings in the cost of care per year times the remaining years, but minus the episode cost. And so we did an analysis of just over 3,000 patients with traumatic brain injury. Their mean age was 49 years. Mean episode cost, again, about £40,000. So that's mean annual savings of around £28,000. Their mean further life expectancy was about 22 years, which is short. That means to say they're living only to the age of about 72, which is much less than the normal life expectancy in the UK, which is about 84. So that does account for the fact that they've got reduced life expectancy because of their disability. But nevertheless, the estimated lifetime savings per patient treated was about £750,000. And that meant that extrapolated across the whole sample, that was about £2.4 billion. And that makes rehabilitation one of the most cost-efficient interventions in healthcare. And that's a really important message that we've been pushing to make sure that people understand that this is really something that governments need to invest in. Next slide, please. So we've recently developed a registry for prolonged disorder of consciousness. We haven't got, at the moment, got data, but in the meantime, we use total FIM plus FAM scores as a proxy. And again, we've managed from that to be able to identify that patients with a vegetative state had FIM plus FAM scores of less than 31, minimally conscious state 32, 35. It identifies
and there's taco seasoning here.
With about 87% sensitivity and 88% specificity. So we've been able to do analysis of those patients. Next slide, please. And again, we can look at the cost efficiency. If we look at the overall group, we've got again, the cost of rehabilitation episode is higher in this group, about £80,000, and the mean annual savings is lower at about £10,000, and the time to offset the cost is a lot longer, 6.3 years, but nevertheless, there's an estimated mean net total lifetime savings of around £167,000 per patient. If we look at the group who remain in prolonged disorders of consciousness, not surprisingly, they don't show any gains in cost efficiency, but if we look at those who are merged, we find that there's a saving of nearly £500,000 in lifetime savings for those, so that we can demonstrate that actually managing that group and bringing that group into rehabilitation, we can give a chance for people to emerge and then move on to rehabilitation and optimize the rehabilitation of those patients. And that will offset the costs of doing our assessments for those people who unfortunately are not going to emerge, and therefore still manage that program. So that's how we've also argued for providing PDOC evaluation programs in this group. Next slide, please. So just to finish, UKROC, it's primarily a clinical registry. The tools are timely to collect. They're designed to be useful to help aid clinical decision-making in real time. Teams want to collect the data because it helps them in their daily practice. We provide other functions for NHS England, so our commissioning database for contract monitoring and payment. Which means to say that they mandate the data, which is good because no data, no pay. So we get lots of lovely data and we get complete data so that we can use that data then for national benchmarking of quality and outcomes and for research to start to look at which works best for which patients. We have our cost efficiency data collected in real life clinical practice. And as I've said, it's a powerful argument for NHS England and other purchasers of services, which has helped to make the case for provision of rehabilitation. And as a result of that, just as an example, in the last year, we've opened another 32 rapid access acute beds in London because we've been able to make that argument successfully. And I think I've reached the end. I'd just like to acknowledge everybody who does all the work.
Thank you, Dr. Turner-Stokes. You know, what we just saw was a heroic effort to distill down the complexity of what this work has entailed to understandable terms. But there, again, we have a lot of learn from what the UKROCS program has done. So thank you very much, Lynn. Look forward to our discussion at the end of this session. Let's move now to Dr. Jan Laversen, who's a senior researcher in elderly care medicine at Radboud University Medical Center in the Netherlands. Jan will discuss his team's collaboration with the Dutch government to establish a longitudinal chain of care for persons with disorders of consciousness, again, sort of singling out that most severely injured group. Welcome, Jan.
Thank you for the invitation. It's an honor to contribute to this meeting. I'll present our long road toward a new knowledge infrastructure in the Netherlands to improve care for these patients, and the subtitle is our mission. Next slide. I do it in this outline. First, background, how we create an expertise network, ENA Coma, and a chain of care for PDOC patients, and knowledge infrastructure in collaboration with our government. And I end with some lessons that helped us and might be helpful to you. So you can let the flowers grow and see windmills instead of windshields. In the next slide, it shows that we do this from a unique medical specialty named elderly care medicine, formerly known as nursing home medicine. It's unique in the world. We have a 3-year postgraduate training program connected to academic networks for research, teaching, and best practice. And the specialty includes rehabilitation, mainly geriatric, but also for younger patients, long-term care and palliative care. And our focus is on severe brain injury and PDOC, our focus of research. And in the next slide shows the situation in the 80s. I was sitting at the bedside in the long-term care. We saw patients without consciousness beyond 10 years who never had a chance to recover. We saw families without hope, professionals without specialty, and everyone without knowledge. And like in our country, your country, we had a first landmark case, Steenesen case, with media attention, discussions in society about withdrawal life-sustaining treatment. Long-term care was problematic. And then our mission started to develop knowledge and to prevent hopeless situations. Next slide shows some milestones in our country. After the first cases, an ethical and medical legal framework was developed in which discontinuing life-sustaining treatment was allowed when there is no chance to regain consciousness. In several studies in the last 20 years, we found around 30 patients all across the country, the lowest prevalence of vegetative state and minimally conscious state in the world. Before 2019, specialized rehab was only reimbursed up to the age of 25. That explains that in 2012, more than 50% of the unresponsive patients had no access to rehab. In 2021, of all minimally conscious state patients, 53% were admitted to rehab. In our cohort study on unresponsive patients between 2018 and 2021, we found 50% withdrawal of artificial nutrition hydration, and some had survived beyond 33 years in nursing homes. The next slide shows a vicious circle. Describing this vicious circle was important to change politics in our country. In a context of suboptimal treatment, there is a tendency to discontinue medical treatment. That leads to a low number of patients whose changes to recovery are unknown. And we convinced policymakers that undertreatment in the acute and post-acute phase leads to overtreatment in long-term care, sometimes beyond 30 years. So if you cut budgets in the post-acute care, you pay a price in long-term care for years and years hidden behind walls of nursing homes. We had to break this circle to achieve appropriate care in every phase. To achieve that, we found a network. Next slide. You see this network, ENA Coma, as a national network of expertise for patients with severe acquired brain injury. In the Dutch, the abbreviation EEN means one after coma, to speak with one voice, where patients have no voice themselves. The network was connected to our existing research group with the mission, nobody should fall between the cracks. We connected 9 care organizations, 1 specialized PDOC rehabilitation center and 8 nursing homes with expertise on severe brain injury and PDOC. And very important, professionals are in the lead with a focus on trust as a core value and collaboration instead of competition. They know what's the best for the patient, supported by management and researchers. And in every organization, a figurehead or linking pin is a passionate professional with time to connect science with practice. A mission and vision is required to participate in this network. The next slides show a national report in which we wrote the vision toward more awareness and appropriate care in collaboration with patient organizations and other stakeholders. The next slide. With the need and urgency of adequate rehabilitation as a main topic, it was embedded in the network of expertise. This important report was built on this national care standard, TBI, in 2014. And I mentioned 2 statements. The first one, organization of care of patients with severe TBI and PDOC, was mentioned in the development agenda, and this is realized. But the next statement helped us a lot. Let the content of this care be leading for organization and funding. So not following the money, but money has to follow the content. Organizational and financial structures and rules should serve optimal care, not the other way around. An important upcoming milestone is the new care standard TBI to be authorized next month. It includes PDOC care with a special recommendation on access for all patients to the specialized chain. Next slide. I show this chain of care at the moment. This is our actual specialized chain of care with access for patients of all ages. Before 2019, it was a labyrinth in a fragmented care, and now it succeeds in getting the right patients in the right places at the right time. At request of the treating physician in hospitals, every patient who opens their eyes without regaining consciousness is assessed on site within 5 days by an expert of the ENA Coma National Mobile Expert Team. Information about the specialized care trajectory is supplied to families and caregivers, including best and worst case scenarios. Patients start as early as possible with early intensive neurorehabilitation in a specialized rehab center. When patients regain consciousness during that program of 14 weeks, they are admitted to regular rehabilitation. When they don't regain full consciousness, they continue the rehabilitation in specialized nursing homes for prolonged intensive neurorehabilitation up to 2 years post-injury. When they regain consciousness during that phase, they are admitted to regular rehab. If not, to chronic PDOC care or palliative care in a nursing home, hospice, or at home. The mobile expert team of ENA coma experts can be consulted in the whole trajectory. The next slide shows where rehab starts. Early intensive neurorehabilitation is a subacute medical rehabilitation program developed in 1987 for children and young adults. In 1994, a specialized team was developed, directed by a rehabilitation physician. The research showed that 2/3 of patients regained consciousness. That was the reason to reimburse the program for patients up to the age of 25, since 2019 for all ages as regular care, and it's reimbursed by the Dutch Basic Healthcare Insurance Act. On the next slide is shown that this program is centralized in one specialized center. It has a maximum of 14 weeks treatment, 20 to 25 therapies weekly, 5 times a day, 30 minutes, with intensive education and counseling families. Almost 50% regained consciousness, 6% died. And the next slide, you see the prolonged intensive neuro rehab, PIN. When patients do not regain consciousness in AIN, they are admitted to prolonged intensive neuro rehab in 3 dedicated nursing homes in the middle of our country. The program is maximum up to 2 years post-injury, 4 to 8 beds available. There is a multidisciplinary specialized team. Counseling families and advanced care planning are very important in this phase. We have a new care program in 2002. And the program is fully reimbursed in the Long-Term Care Act by the government. In the next slide, you see that we follow every patient during intensive neuro rehab in 2 PhD studies with a 2-year follow-up on outcomes and impact. On the left side, by a rehabilitation specialist, and on the right side, by the elderly care physician, including quality of life, quality of dying, decision-making, impact on caregivers. The protocols are published in 2021, and most results will be published next year. The next slide shows chronic PDOC care and or palliative care starting after the rehab phase in 2 to 4 regional centers of expertise with a minimum of 2 to 4 beds. The team is led by an elderly care physician. The recently developed care program includes advanced care planning, moral deliberations, end-of-life decision-making, and family guidance. The next slides show the recent support of our government under direction of the Ministry of Health and Welfare and Sports, and directs the transition to centers of expertise and long-term care. This is developed for target groups with low prevalence and high complexity, such as Korsakoff, Huntington disease, and PDOC. And the aim is to improve quality of care and knowledge infrastructure by concentration. All groups need to comply with audit-proof criteria, which were judged in independent audits. After approval by a committee of the ministry, ongoing funding is provided for the knowledge center and centers of expertise. Not only the treatment, but also the knowledge infrastructure for research and a learning community. Every group is organized in an association with boards of the nursing homes and a representative of a patient organization in our board. So patients are on the driver's seat. The next slide. And these are the topics, the audits of the Knowledge Center. And you see that we received accreditation of 4 years. We met all criteria at the maximum level. We have 5 competency profiles, a lot of research, expertise, website, and a shared data system. I show you in the next slide. In this centralized system, we have a dashboard to monitor referrals, admissions, time between referral and admission, level of consciousness at admission and at discharge, occupied beds, average capacity, etc. And every week, all physicians of our network have a call to discuss patient transfers, obstructions, and solution. So the next slide, what was helpful to us and might be helpful to you. First, the facts, results from many studies, in particular prevalence studies. The evidence of the low number of patients helped government agencies to reimburse the extra cost for rehabilitation. The unity among connected experts speaking with one voice has helped us to give our patient a voice in collaboration with their families. Compassion and personal commitment connected to trust and the support of families, many organizations and agencies. It helped that we had no financial, religious, or political incentives. Our mission was driven by passion. And last but not least, the societal impact in collaboration with families, the connection of their impressive stories, and the knowledge and experience of professionals and researchers. And I end with 2 lessons to cross the bridge. Hopeful for you. Appropriate care in each phase is possible. And the phase of rehabilitation lays the foundation for a meaningful recovery or a dignified letting go, both with love and the best care. And nobody with PDOC falls between the cracks. This mission is realized in our country, and for your situation, I wish exactly the same. Thanks for your attention.
The common denominator for me in listening to both Dr. Turner-Stokes and Dr. Laverson is that they were able to take what were really fragmented, disintegrated systems, and then again, working with federal partners, turn them into coherent systems that were reintegrated. And one of the other commonalities was having registries, being able to perform the surveillance that is necessary as a starting point. And right now, we're not in the States. We're not able to do those things yet. So that is our main task. Okay, let's move now to the next speaker. Dr. Alexey Turjan is professor at the University of Laval, and a Canadian research chair in critical care neurology, specializing in TBI research through the Canadian TBI Research Consortium. Dr. Turjan will discuss the partnership that he has been one of the leaders in between Brain Injury Canada, that's sort of the analogous organization to our Brain Injury Association of America, and the Canadian government to improve access to care for moderate to severely injured people with TBI. Welcome, Dr. Turjan.
Thank you. Thank you very much, Professor Giacchino. Thanks for this invitation. I'm glad to be here. It's been a great day so far. I've listened to all the talks this morning, and it was very, very interesting. So I'm here on behalf of my colleague. Just a few slides.
Apologies.
No worries. On my colleagues from the CTRC. So the CTRC is the Canadian Traumatic Brain Injury Research Consortium. So I'll first give an overview of what our group is about, the group that I chair with my close friend and colleague, Jamie Hutchison, who's a pediatric critical care physician in Toronto. And then I'll go with our project that we've worked together with Brain Injury Canada on making TBI being recognized as a chronic condition. So the vision of our group first was to create, originally when we started it in 2015, a collaborative, integrated, and impactful consortium structure for the Canadian TBI research community, aiming at elevating Canadian research in the field to a new level. Why is that? Because there's been research done in silos everywhere in the country, as it is still ongoing in several regions in the world. And the way was to bring people together and make our research being more impactful. Next slide. So the group is formed of researchers that are from basic science, translational research, acute care research, clinical applied research, rehab research, pediatric adults, mild, moderate, severe. So it really is a group formed of individuals that are researchers, that are scientists in the field of traumatic brain injury. And what this group and this consortium is for from the beginning is to facilitate linkages, communication, and KT across this community, making sure that what we do and the research we do, if there's 3 or 4 researchers working on the same topic, same problem, that instead of working on it on their own, that they work together and develop larger scale programs, multi-center, that will integrate within the national TBI research efforts and align with what's going on more globally. It's all driven by investigator-led research. So our members are all investigators that bring the research basically to the group to get that research being endorsed, and the group help everyone to improve the research or programs so that it's more impactful in their development and conduction. Next slide. So I chair this group with Jamie Hutchison. We created it in 2015 with the help of the Canadian Institutes of Health Research. So we obtained funding from our national granting agency, but the funding is about funding for meetings, funding for some of the infrastructure and coordination, but it's still about making sure that members also bring their own share of organizing these meetings that we have twice a year, these scientific meetings where we discuss research. Next slide. So we have an executive committee that we chair with colleagues from all across Canada, from different fields. You know, some of them rehab, more basic science, psychology, psychiatry, neurology, or pediatrics, or critical care. And our group, our executive committee organized the meetings, the operation of the CTRC. We have a coordinator, Olivier Costos, but also the whole strategic planning. And as you can see, Michelle McDonald, who's the director of Brain Injury Canada, is part of the executive committee. And she's been very, very good in helping us out to bring the voice of TBI partners and individuals across Canada to the room, and making sure what we do is relevant to them. Next slide. So we have 3 other committees or platform: a training and care development committee, where we nurture, mentor, and support trainees in their either at their graduate study training or residents or fellows. We have a trainee day where they can talk about their research, get input from the scientists and PIs of the group, and it's extremely appreciated. This is part of our just before our scientific meetings twice a year. We also have a knowledge synthesis platform with a teaching session and exhaustive teaching course of methods to help out our members in their programs about knowledge synthesis. And we also have a grants and manuscript review committee, which makes that every grant proposal that are submitted to a granting agency and every manuscript coming out of one of the program endorsed by the CTRC are reviewed internally by members of the group, not involved directly either in the program or in the manuscript, so that they get some sort of an independent review aiming at improving their work. And it's something that is collaborative. So if someone has helped someone out with their grants or manuscript, it's going to be the opposite way around for them when it will happen. Next slide. So scientific meetings happen twice a year, and they are designed to be open and inclusive. Our group is designed to be open and inclusive, meaning that all Canadian researchers in TBI can be a member of the group. There's a very small registration fee. It's more about making sure people are really committed to the group. And the commission is to help out others. But the way our meetings are set up is they're set up by the membership. Basically, members send a presentation request, they submit a structured abstract of their project or program, and questions that they know ahead of time that they could ask the group, and they can have other questions for sure. But in order to the members to know what will come and be prepared to help them out. So projects or programs are presented. We have 30 to 45 minutes presentation. And the good thing is, it's not about presenting results. It's about presenting protocols, presenting ideas, presenting pitfalls or questions on while a study is being conducted, and how the group can help to resolve these problems when we're doing multi-center research. And we plan at least 50% of the presentation time for questions. So if we have 45 minutes to present, then it's going to be half of the time for questions and discussion, which is very rich. And members in the audience will basically provide input, whether they're involved or not in the project. It doesn't really matter. It's all about helping, and then when they're presenting, it's the opposite way around. So projects or programs are endorsed by the group, and then members will need to present at the next meeting or every other meeting, depending on where they are, and collaborators may help them out, and we minute discussions so that they can get a written output from the discussion. Next slide. We have more than 400 members, 150 researchers, several trainees and students that comes to the group, and trainees and students will learn a lot by listening to the presentation of the PIs, of those who present large-scale programs, and they will know also and be helped if they want to really pursue it as scientists and professors and researchers to know what needs to be done thereafter. And our membership represents 75 different institutions and more than 150 independent research projects over the years. It's been close to 10 years now. We've had a little bit less than 20 meetings, and they've been rich from the beginning. We have one meeting out west in Lake Louise in January in a secluded place where we are sure people talk to each other. It's about building trust in such type of environment, and we have one in the east in June. Next slide. So we have a strong patient partner involvement. So we have patient partners within the group that assist to our meeting, that will provide input, but we also have Brain Injury Canada, our gold patient partner organization with Michelle McDonald as part of the executive committee. She is involved. She'll bring the necessary needs that we have, but also making sure that the people she represents are well represented in our consortium, about how we prioritize research, but also how we develop programs and involve patients in our programs. Next slide. And this collaboration over the years led to several discussions, and a bit more than a year and a half ago, when we were in Montreal at our Eastern Canada meeting in June, we had a long discussion and a long meeting with Jamie, myself, Michelle McDonald, and others, and Kathy Hendricks, who's our communication specialist, on how can we send the message to improve the literacy of TBI in the community and in the country? Because we realize that TBI is perceived, or was perceived, as a once or a single condition from which either you die for or survive, but if you survive, you go back to your previous condition. So the literacy of TBI is not that it's a condition that you'll have to live with over the years. Next slide. So in Canada, we have recognition of some chronic disease, close to 30 of them, which makes that we wanted to emulate the same type of recognition for TBI, because we all know, and I don't think I have to convince anyone in this audience, that it is a chronic condition. But how can we make it recognized as such when there's no specific programs of rehab in several provinces, or the recognition at a stakeholder level, of political level, is not very well understood how chronic this condition is. And we all know it's devastating, but it's not a single event, and it requires complex care. Next slide. So I've listened to very great testimony earlier on today, and I'm not going to go very deeply on this, but suffice to say that when you do such type of work, you need to have patients providing the voice. They're the ones that are able to providing and explaining everything that happened to the community and to politicians. Next slide. So in Canada, we're a large country. We're the second largest country in the world, but we're fewer than 40 millions. The cause of our TBI is, however, the same as everywhere. Falls with the aging population is one of the major one. Motor vehicle collision, for sure. A lot of our TBI, especially in the youngest population, sports. Assault, yes, a bit. Probably not as much as in the United States. We don't have much penetrating firearms or other weapon-related TBI, but we have some for sure. But suffice to say that it's a classical representation of TBI. Next slide. So TBI affects daily functioning, independence, and integration of patients when they're back home from a cognition, physical, behavioral, emotional, or sleep disorder. Next slide. Or also from a social and financial impacts. It's large, it's huge, and as we all know, it's not a switch on and off. You have a TBI and you don't have it anymore. It's some sort of a dimmer with a range of disability of impact that's going to change your life and the life of your relative. In Canada, we work in a universal healthcare environment where there's no private hospitals. It's all public, and care, regardless of what you earn, is the exact same all across the country. But it doesn't mean that we don't care about healthcare costs. And it also means that our stakeholders and politicians needs to know how much it costs. And then when you don't have a recognition of TBI as a chronic condition, and you don't have it as a condition per se, other than in the acute phase, it's very difficult to understand whether you're putting the money at the right place and whether we should build or develop different type of programs that could help decrease healthcare costs, but more importantly, improve care at the bedside. And if it needs more funding, then it has to be redirected there if it's what's needed to improve long-term outcome of these patients. Next slide.
And just a quick, about a minute.
Yeah, okay. So this chronic recognition as a chronic condition will help to be in the Canadian surveillance data because there's a lot of limitations here. And we know TBI affects vulnerable population as homeless and indigenous or intimate partner violence. So being recognized will help to have a better surveillance data and know better what's going on in the country. Next slide. And it's a call to action to be part of this Canadian chronic disease surveillance system in Canada that is specific to our country, but there's similar ones, I believe, in other countries and in the US that will help to really reorganize the way that we treat for these patients in the long run. Next slide. And this effort went to a support Bill C-277 that it was led by one MP of one minority party, but now is endorsed by all parties in the House of Commons in Canada. It has its third hearings a few weeks back, and we hope, if there's no election, that it should pass, and then we'll establish a national strategy on brain injury and have a recognition of TBI as a chronic condition. Next slide. So for those who want to know more about the CTRC, we've published an overview of our group and how the group works. Thank you very much.
Thank you so much, Alexei. The parallels are obviously very evident, and I'm glad we've opened discussion between our team and what you've done there, and look forward to further conversation. Let's move to our next presenter. Kathy Hendrick is a communications specialist and advocate for persons with TBI. She's speaking on behalf of the International Initiative for Traumatic Brain Injury Research, or INTIBER. So INTIBER was an organization basically that was initially supported both by NIH, Europe, and has grown now to include Asia and other countries. And its focus is on global collaboration to improve research and outcomes in TBI care. And again, you're going to see parallels with the local work that we're doing here. Welcome, Kathy.
Thanks so much, Joe. It's a real honor to be part of this group of leaders. Everyone participating in this, whether living with a traumatic brain injury or contributing to the science or the advocacy. You're all leaders, so I feel very honored to be part of this. I want to thank Alexi for laying a nice introduction to the next stage of work that we're doing in Canada. We are working together through the leadership with the Canadian Traumatic Brain Injury Research Consortium and with the INTBIR, which is the International Traumatic Brain Injury Research Group, a global coalition to establish a resolution on traumatic brain injury. Thank you for through the World Health Assembly, and I'll talk a little bit about that. This global movement is stemmed from what Alexi just talked to you about. We drafted a paper, a position paper on aggregated data in Canada. And when you looked at the picture in totality, it was certainly shocking to me, less so perhaps to others in the field, but the aggregate picture is terrible. So our key milestone, as Alexi told you, was to get a position paper co-authored by Brain Injury Canada and the CTRC to influence policy and to lead to and support new legislation that we're hoping will be passed. Next slide, please. So our country, just generally, and Alexi talked about this, but our country is no different, and perhaps it's worse, but it's no different than everywhere around the world. Of our homeless population, over 50% of our homeless population are living with a serious TBI. Of those who survive TBI, they have a 2.5 times greater chance of being put in jail than the average population. Our Indigenous population, we have virtually no data. They live in isolated communities. Many of them go untreated. Many of them end up with the comorbidities that exist with TBI. There's no long-term care. Of the primarily women who survive intimate partner violence, 60% of these have serious TBI. And as you all know, once you've got a TBI, in our data, 75% of those who were employed, that drops down to 13%. Next slide, please. So why is Canada leading the World Health Assembly resolution work? Well, Alexi talked about it. We've got pending legislation that we're hoping will be disrupted by an election, but it funds a national strategy. It mandates the Minister of Health to enhance brain injury awareness and prevention, but most importantly, I believe it insists on gathering standardized data. Joe talked about the difficulty of getting that in the US. We don't have it. We have little bits of data here and there. Writing that paper, position paper, was very difficult because the data was so spotty. And ultimately, with data, we hope to improve treatment, rehab, long-term support. We also want to help with prevention and education. Next slide, please. We've also got an awareness campaign that's going on right now. It's a 125-day submission by an individual living with a brain injury to the Minister of Health. And that submission that comes in every single day that our legislative house is sitting, there is a reminder that Bill C-277 must be funded, must be passed. We need the data and research, and Brain Injury Canada has been a tremendous partner in helping to express the views of those with lived experience. Next slide, please. So our global coalition, this started when I attended the INTBIR meeting in Bethesda in end of January, along with Alexi and a whole group of incredibly dedicated people. We listened to Dr. Terry Reynolds talk from the World Health Organization that if we took a look at TBI and how the long-term chronicity of the condition is ignored, not in developing countries, not in lower income, middle income countries. It's denied to people everywhere. You should get a resolution. You should get the World Health Assembly resolution. Now, for those who aren't aware, the World Health Assembly is the governing body for the World Health Organization. So if the WHO comes up with a resolution, it gets adopted by the World Health Organization. So these are just some of the groups who are involved in our coalition. We have about 15 people on the governing coalition, but it is growing with representation. I'll talk a little bit about that in a few minutes. But January, at the Intabir meeting, I and several others were absolutely motivated to do something to change this and to drive the resolution on TBI. We have patients, caregivers, policymakers, clinical scientists who are working on the draft of the resolution. And it's very ambitious, but we're aiming to have the endorsement by World Health by May 2025. Many people have said it's impossible, and I love hearing that because it makes it fun, and we're going to do it. Next slide, please. So you all know the global barriers to rehab post-acute care. I won't spend any time on this. It's worse in lower middle-income countries, of course. Their financial constraints, the high cost of rehab surpasses people's personal resources. Particularly, I think of Canada, the geographic isolation, and there are limited specialized services. They're very, which is interesting, the health human resources impact, very limited resources for the neurocomplexity of serious TBI. Next slide, please. The other issue is just low prioritization. So this is why we're working on a WHA resolution. It's just not prioritized. As much as we recognize the chronic nature of TBI, we know that people, once that bump on the head comes, a serious bump, they're not the same person. And governments don't classify TBI as chronic. They classify other neuro conditions as chronic, but strangely not TBI. The other issue, and I interviewed in drafting the paper, our position paper, I interviewed over 50 people living with TBI, and the stigma is crippling. They are often described as being drunk, being out of it, on drugs, and they're dismissed. So we believe that getting global standards on common data elements is going to go a long way in raising our priority. Go ahead, please. Just a change on next slide. The 3-hour rule for rehab. This is just a very good example of the exclusionary, discriminatory approach to TBI and what people with TBI live with. It just showcases the complete dismissal of what a serious case of TBI means to an individual, the family, the community. And so its biggest problem of many problems, it's driven by financial incentives over patient needs. So the 3-hour rule is a glaring example. It will face global criticism as we do our work, but it's not the only example. But I raise it here as one example. Next slide, please. So why do we need this resolution? We need formal recognition by the World Health Organization to elevate TBI to a global health priority. We need standardized care and data. This resolution could lead to standardized rehab protocols, improve data collection, enhance our care outcomes, and drive evidence-based policymaking. It'll address the socioeconomic impact of the terrible employment rates, people who have TBI, the higher rates of incarceration and homelessness. It will promote equity It'll promote accessibility, particularly in lower middle income countries, but in every country. So in short, what this does, it's not enforceable. You can have a WHO resolution, the World Health Organization can adopt it. It's not enforceable, but it raises enormous profile for something that needs to happen. And as Terry Reynolds called it, you ride a wave of advocacy. So that's what we're going to do. Next slide, please. So our thank you. Our priorities are to get several of the member states on board, engage in diplomatic outreach, and get some evidence-based advocacy. Next slide. We were reaching out to high-income countries, LMCs, conflict and disaster zones. We have got several people involved in reaching out and getting endorsement from these various member states. Next slide, please. We're focused on data aggregation everywhere. We're focused on an economic impact analysis. I'm happy to hear from many of you today who touched on this. Our deliverable is the resolution, and we're developing briefing documents to support that. Next slide, please. We've got an advocacy and communication plan that is underway, and we're implementing it. We're happy to share that with any of you. And next slide. We're promoting it throughout the world. We need endorsement. We need people, good partners to collaborate with us. The G4 Alliance, already embedded in the World Health Organization, has prioritized this resolution on their agenda items. That's a huge step that happened last week. Next slide, please. So the vision is to establish TBI as globally recognized, notifiable, ensuring equitable prevention, long-term care. Here are just some of the great people involved. Next slide, please. My question, my call to action is, can we count on your advice? Can we count on your endorsement? Can you please sign up to help us on this? Because the more people we have endorsing this and direction and advice from you, the better we'll be. Thanks so much, Joe, Sarah, Mary, the team. This is something of a miracle to get this group of people together. If we can do this, I think we can get a resolution. Thank you.
Thanks so much, Kathy. Really appreciate it. I think we can turn to Intabir and put a little bit of pressure there to be sort of a coordinating organization for all of these efforts, which, have become global. Next speaker is Dr. Claude Hempel. So Dr. Hempel is the Kenneth Rainin Endowed Chair in Neurocritical Care at the University of California at San Francisco and the Chief of Neurology at Zuckerberg San Francisco General Hospital. He leads the Curing Coma Campaign. If you don't know about the Curing Coma Campaign, he's going to tell you a little bit about it. You can also Google it. But it's a US-based initiative that's aimed at advancing the science and the care of persons specifically with disorders of consciousness. Obviously, there are lots of lessons learned for the larger group of people with severe TBI as well. Welcome, Dr. Hempel.
Well, Joe, thank you so much for having me and letting me talk about the Curing Coma Campaign and the Neurocritical Care Society. Next slide. So just a little background that the Neurocritical Care Society is a multidisciplinary medical society that's focused on acute care of patients with, let's say, neurological catastrophes, traumatic brain injury being really at the top of the list. And it's emergency and intensive care unit management with over 3,200 members, physicians, nurses, pharmacists, clinical researchers, translational researchers, therapists, and the mission includes research, education, and outreach. And so we might think of our role in acute TBI as saving the patient's life, and then preventing, limiting, and secondary brain injury, and preparing the patient for recovery and rehabilitation to receive that. and obviously working with families, because many times injuries are significant and sometimes they are quite severe. Next slide. So why are the intensive care teams thinking about curing coma? Next. And next. You know, really these, and next, these are the questions that we get asked. Are they going to die? Are they going to wake up and be able to talk and understand us? And is there anything we can do to increase their chances of recovery? And we know that these are the questions that are posed every day, and they matter the most to patients, their families, and to us. Next. Next. And this cuts across the diseases we're treating neurocritical care that includes TBI, as we said, is perhaps one of the most prominent diseases. But we were asked at the very beginning when we developed the Curing Coma campaign, well, tell me, what do you mean? Define curing coma. So we defined curing coma as promoting recovery of consciousness through early intervention and long-term support. And we use the term coma, but really we're talking about the range of disordered consciousness with a focus on recovery. Next slide. And I think this goes back to that question that we get asked every day. How is the patient going to do? Is there anything we can do to improve that outcome? And how we do prognosticate coma recovery. The current state is we use a lot of data. And that data is generally what the patient's neurologic examination is right in front of us, demographics like medical comorbidities, anatomic imaging on CT and MRI. And there are actually some pretty fancy models of mathematical models and prediction models that are developed. Next slide. But we have a problem, and this has been alluded to throughout this summit today, and that's the issue of the self-fulfilling prophecy. And unfortunately, nihilism has been a common theme in the acute care of TBI patients. Next. And we have a lot of research data that looks at this notion of a self-fulfilling prophecy, which is basically a patient who has care limited due to a presumed poor prognosis, but that patient can and would recover if otherwise they were treated aggressively. And I think that many times folks think that this care limitation is related to withdrawal of medical support, and that was referred to earlier in the summit and in several other speakers' talks. But really, any type of care limitation should be addressed. And in fact, when we choose not to deliver rehabilitation services and therapy to a patient for this reason, that is a care limitation. Next. So why aren't we better at prognosticating? Well, the problem is likely that we are currently assessing what the patient looks like now, rather than assessing the true underlying mechanism of impaired consciousness and the capacity of the brain to recover. Next slide. So the Curing Coma campaign was kicked off in 2019 with some initial seed funding from the Neurocritical Care Society with the goal of having a platform to enable two interrelated aspects. One is focusing the science of acute coma and disorders of consciousness on identifying and testing therapeutic interventions, not just prognostication, but therapies, but also form that enduring community of providers, scientists, and advocates to test and implement these advances. We emphasize that everyone has a role in the Curing Coma campaign, which means there may be cognitive scientists, there may be rehabilitation specialists, or a bedside nurse that takes care of these patients. We want to create and enable a platform for participation. This is just an organizational chart that shows a number of different working groups that range from coma science to pediatrics to World Coma Day. I'll tell you a little bit more about that shortly. Next slide. Joe Finns showed this study and introduced the concept of cognitive motor dissociation. And I want to say this is really, really important and I would say a game changer. A number of studies have brought this forward, a number of research studies. This is the most recent and the largest. But for those that aren't familiar, the idea is that we have patients in front of us in the intensive care unit or in the post-acute rehabilitation or skilled nursing facility setting, and they can't follow commands. And so they are tested, they may be tested in a research setting with functional MRI or advanced EEG with machine learning. And in this study, 1 out of 4 patients, next, was able to activate these EEG and fMRI, even if they couldn't follow clinical commands. What does that mean? That means that probably at least a quarter of our patients who do not appear to follow commands, do not appear to participate when we examine them clinically, are actually following commands and participating in their mind. Next. And patients with this CMD are about 3 times more likely to have significant recovery. But these are really research tools now. Next. So the Curing Coma campaign started off really as a scientific focus, and the first scientific pillar is endotyping. So phenotyping is what a patient looks like. Endotyping could be thought of as why they look that way. That's really the key, and finding biomarkers to be able to assess that. We know this is a grand challenge. And really to emphasize the continuum from acute care to recovery. It is what our patients and families experience, but we fragment it, and we fragmented the science and the clinical collaboration as well. Next. So some of the work we've done so far, a number of different gap analyses on classification, mechanisms, trajectory of recovery, therapies. Next. That have brought forth, I'd say, some provocative notions about how we might improve the way we identify these patients and the interventions we should be testing. Next. We've been fortunate to partner with the National Institutes of Health and had a symposium. The first one was in 2020. It was virtual because we had planned it in person, but that's where we were in 2020. Next. And there were proceedings that were published from this virtual symposium. Next. And then a follow-up symposium the next year, where the proceedings were really, each of the recommendations that came out of this could form a grant application, and several of them have so far, or an RFA. Next. We developed common data elements that have just come out a few months ago, because one of the problems we have is speaking the same language in clinical research and potentially in registries as well. We know that NINDS has common data elements in a number of different diseases, and so these are now published, and they're also available for download and use, and we're collaborating with NINDS regarding hopefully moving these into the NINDS repository next year. Next slide. And then I mentioned World Coma Day before, and so we've created World Coma Day as an opportunity for collaboration and connection. It started in 2021 as a virtual online opportunity for provider education and linking together scientists. But this is this is the map from 2023, where we had participants from 100 countries. And we've really appreciated that a number of places that may not be involved in science, but they're certainly involved in care and advocacy, appreciated the opportunity for shout outs and stories of hope from ICUs, rehabilitation units, research labs, patients, and families. So this past year, we utilized a YouTube format and have had over 43,000 views. And we're pivoting a bit for 2025 to try to enhance our opportunity for patient and family outreach as well. Next. And so just a reminder about how common TBI is in our world, in the acute care world. We did a study called Come Together, which is basically an international survey of providers, what tools they use and what patients they see. And there are 41 countries, although most of the respondents were from the United States. And what we see is traumatic brain injury is way at the top of the list. This is where our patients start. And it directs where patients survive, whether patients survive and where they go. Next slide. So next, when we think about curing coma, we really are coming around to appreciate that curing coma is a lot about culture change, moving from a culture of pessimism and nihilism to what we call awakening hope. Next. And recognizing prognostic uncertainty, and that we really have a biological basis of prognostic uncertainty when we think about that cognitive motor dissociation lessons. Next. And recognizing the limits of our clinical neurologic examination and how that's really not a great tool for us to decide the capacity for patients' recovery and to potentially limit care. Next. And so really shifting from phenotype to endotype, treating patients based on the potential for recovery, not just what they look like in the moment. Next. And I think one of the challenges is, and we see this just in our own setting, without rehabilitation for recovery, there's a negative feedback that reinforces nihilism in the ICU and the acute care setting. And that's a problem as well. So thank you very much for the opportunity to be part of this, and I'm looking forward to the discussion.
Well, thanks so much. I want to credit you for, again, being one of the forward thinkers who realized the importance of pulling together the critical care community and the rehab community. And you've done that very well, and it has really sped us up. So thank you. Our final speaker in this session is Dr. Michael Chu. So Dr. Chu is the Chief Medical Officer and Senior Vice President at Paradigm. Paradigm specializes in workers' compensation and traumatic brain injury management. He brings a payer perspective to this discussion, as well as his knowledge of healthcare solutions that balance cost effectiveness with optimal patient outcomes. Very different approach that we're going to hear about. Dr. Chu.
Great. Can you hear me?
Ken.
Perfect. Great. Thank you, Dr. Giacino, for the introduction, and good afternoon, everyone. It's certainly a privilege for me to be here with all of you, and I have to say, it's been an inspiring day for me to listen to all of the initiatives that are taking place, both domestically and outside the U.S., in trying to get more access to the state-of-the-art, TBI care as well as rehabilitation across the globe. So very inspiring. As you heard Dr. Giacino talk about, my goal today is to share with you my point of view on, I guess, the current payers perspective in the U.S. And I would submit to you that even though we heard a lot about the challenges that exist in the U.S., we do already have a proven payer model that seems to be able to instill or facilitate the collaboration between the payers and the providers to achieve the best outcomes for our patients. And that payer model really is in the realm of the workers' compensation that I think Dr. Giacino talked about. And the reason why workers' compensation actually is a proven model for us and for the industry is that if you really try to better understand what distinguishes, what's unique about the workers' compensation payers, is that the goals of care have already been very clearly defined. And so what I mean by that is that obviously, as you can see in this slide, there's a lot of goals of care, from survival to medical stability to function and all the way up to achieving a sense of great well-being. And when it comes to workers' compensation, there's a mandate in the workers' compensation regulation that says that the goal for care has to be two things. One is that the care has to be delivered to the injured worker so that we can restore their function or their health status back to their pre-injury state. That's very important to understand because obviously it goes back to where their health status was prior to the injury. And if we cannot achieve the restoration of their health back to their pre-injury state, then we have to do everything in our power to go ahead and achieve the best functional status to help the injured worker be as productive as possible. So when you look at this goals of care, obviously it's not just the medical stability and survival that we're focused on. We're actually focused on the functional level when we are looking at the provision of care and all of the medical necessity elements that goes into providing care. And so this allows Paradigm to really do what we have been doing for the past 30 years. And if you go to the next slide, Joe. Obviously, we've been residing in the workers' compensation space for the past 30 plus years. And for those who may not be aware of Paradigm, we are a national care management company that specializes in catastrophic injuries, specifically brain injury, spinal cord injury, polytrauma, burns, and complex amputations. And where we actually have learned to provide a value-based and outcome-focused approach to care management. And what the workers' compensation payer requirement allows us to do is to really truly adopt this systematic care management approach that we've been hearing about today that works. It's been proven. And what we are clearly able to do in the workers' compensation space is that we can adopt a team-based approach where we are able to put a team around the patient, where we're not only bringing in medical experts and surgical expertise, but also behavioral health experts, as well as on the ground clinical specialists like network managers who can elevate the health literacy of our injured workers and their families, and really and make sure that the team is working toward achieving the outcomes that we want to achieve and guarantee with our care management. And I think there was a mention about the approaching this care management approach in a very holistic, whole person care methodology, which is the biopsychosocial model of recovery, where there's been plenty of studies that showed that recovery outcome is not just based on the biological component, but the psychological and the social components as well. We also work very closely with what we consider to be centers of excellence. And now, centers of excellence has been maybe perceived in different ways across the country, but how we view centers of excellence are really facilities that are infused or they're staffed by experts who are truly knowledgeable in the condition-specific diagnosis that we are managing. And it goes beyond acute care. We actually identified high-performing provider facilities that are in the realm of inpatient rehab facilities, LTACs, post-acute, transitional residential rehab facilities, who are needed to ensure that our injured workers progress to the best functional status as possible. And with that, obviously, to show that it does work, if you go to the next slide. This is just an example of a kind of data from Paradigm that I was able to pull. And so from the past 7 years, from 2017 to 2024, the referrals that we've been getting from our workers' compensation clients and carriers and partners fall into this category, where brain injury has started to exceed the diagnostic condition that we get mostly requested to take care of, followed by the multiple trauma. If you go to the next slide, if you look at the outcomes of these catastrophically injured claims, which tend to be the worst of the worst, as you can see on the left side, close to 70% of our patient population, we're actually able to achieve a release return to work status, which is tremendous when you think about the fact that how impaired these injured workers are at the time of injury, where they're not responding, they have significant impairments. Over the 2-year period of time, we're able to actually get them back to a state where they can return back to work. And for those smaller percentages, 32% that they cannot be released, returned to work, majority of them are actually well integrated into the community. And just to show on the right, it's not that only certain age categories can be restored or rehabilitated to this point. As you can see, all age groups that fall into the workers' compensation age category do and can have the ability to be restored or rehabilitated back to a functional status. Next slide. This is a specific data point for traumatic brain injuries. If you look at the left, I want to confirm that even for the most severely injured TBI patients, a great majority of 52% of those that we take care of are able to be released, returned to work within 2 years. There's a larger percentage of people, because of their severity of the cognitive impairments, they cannot be returned to work. However, they're appropriately integrated to the community with really quality of lives and the productivity level that can be maintained. And again, to show on the right that the age is not a factor from being released, returned to work. Next slide. These are some additional clinical outcomes that I've been monitoring and reporting on. And this is to show that there are durabilities to these good outcomes if you do it right, if you do it early. and where we follow these patients, our injured workers, a year after we return the patients back to the carrier after achieving our outcomes. And close to 80% of the injured workers that we manage, including brain injury patients, do not require any in-house, in-home care, which means that they're independent enough to really function fully without any other support systems. And then on the right, we have actually followed the patients a year out after returning patients back to the carrier after achieving outcomes. And it turns out that 96% of the people have achieved the medical stability so that they never have to go back to the acute care hospital with complications. Next slide. These are some additional steps that we have taken from Paradigm's perspective, where we actually went outside of our internal purview, and we involved an external actuarial company known as Milliman's, and they've done the data analysis of our cases, and they have determined that because of our active engagement, early rehabilitation involvement, and the use of highly expertise-driven and performing providers, we were able to achieve 32% lower lifetime total medical cost savings, as well as obviously, as mentioned before, getting people back to productivity, reduced return to work, and including competitive employment. And this is an external study that we've been able to repeat every so many years to go ahead and confirm that what we do and the approach we're taking actually do have an impact, both in cost as well as functional status. Next slide. So I guess I want to end with the takeaways from at least my experience in being in the workers' compensation space, is that I do believe when it comes to payer relationships, I think it's very, very important to get goal alignment as to the care goals, as we have done with workers' compensation. And I think if that can be somehow propagated to other payer types, I think we can go a long way in achieving better outcomes. Number two, it's very, very important for the providers and all of us to focus on the outcomes management. I think it's not about activities, it's not about what's being done, but what's being done to achieve the outcomes that we want to achieve. Can we get there faster? Can we get there better? And I think that's the focus that we all have to, I think, realign ourselves with. And then lastly, I do want to reinforce what everybody's been talking about here already, that early engagement in rehabilitation, especially in traumatic brain injuries, does improve outcomes. I think that has been a proven element, a factor that's been kind of reviewed throughout the course of the day, and I certainly promote and extol that element as well. So with that, I'm going to turn this back over to you, Joe.
Thanks so much, Michael. I think one observation is, I think workers' comp is sort of a single payer model, and it's very different. The approach differs remarkably from our system, in which insurance support and coverage are handed off all through the course of recovery. So no one ultimately is really responsible, and that's a defining difference. And that difference obviously leads to a very different way of thinking about how care should be provided and then implementing it in a different way. So I think we need to keep that in mind. Okay, so we're at the point now where we're going to open up for discussion. This is broadly open now. So I will start us off just to kick things off a little bit with the last panel, but it's open game now. So we wanted to save a chunk of time at the end for people to ask questions. So please put your questions into the Q&A portion of Zoom, and we have people who will be looking at them to try to, I don't know if we'll be able to handle all of them, but feel free to use the Q&A to put your questions in, and we'll take it from there. Following that, we will go to next steps. We'll have one more speaker, which is Laura Brown, and it's about another event that I want you all to know about that is very complementary to this one, and it's happening in 2 weeks. So Laura will talk a little bit about that before we wrap up. Okay, so thank you all. And by the way, remarkable job staying on time. Everyone, thank you for that. So let me kick us off, and I'm going to direct the first question to Doctors Turner-Stokes, Laverson, and Turgeon. And given where we are here in the U.S. In our thinking about this and what we have to do, can you just briefly talk about how did you spark the interest and engagement of your government partners? How did it come about? What did what got that going? So, Lynn, can you speak to that first?
Yeah, I think I saw my role as general nuisance, and basically, I think I sort of gate crashed every committee that I could, mostly going through the Department of Health, as it then was NHS England, as it's now called, but essentially just gate crashing committees, getting in there, and I think I'll go to my grave with "and rehabilitation" on my gravestone whenever I got in a discussion about setting up major trauma networks or out of hospital cardiac arrest or whatever it is. I was just in there with "and rehabilitation." So that was one thing, is just getting your knees under the table and being there. And then the second was having the evidence. So in the early days, I spent a lot of time doing Cochrane reviews. I've given those up for Lent, by the way, in the 1990s. But I assembled the evidence to be able to say, yes, rehabilitation does work. And then, of course, we not only need the evidence it was effective, we needed to show it was cost effective. So we went out to try and get that information. And I think those were the two bits. It's being there on the one hand, and then having the evidence to really push your point home. And there's no change out of it. You can't just sort of be there and shout. But having compelling evidence was important as well.
I completely appreciate that expression, "and rehabilitation." Right. So what I hear you saying is it's not allowing rehabilitation to be an afterthought. And it really doesn't make any sense. The amount of time after somebody has a catastrophic injury that they spend in acute care is a tiny fraction, obviously, of the rest of their life. And it's rehab that has the role for the rest of their life. One of the things I was going to say during or after Dr. Manley's talk is, we invest all this upfront money, resource, and care with really no constraint on what we do. And we do a phenomenally good job. We save almost everyone's life. Most trauma surgeons and critical care physicians will say nobody dies from traumatic brain injury because we can save that person's body. It's what happens after that. Dr. Laverson, same question. How did you spark the interest of the Dutch government?
Yeah, I think it started at the time of the first cases in the 80s. I mentioned that there was a famous case, like in your country, the Cruzen case, and the government was very concerned about how to solve the problem of hopeless situations in nursing homes and the discussions in society, how we can solve that problem as a shared responsibility. And I think this important was we told the whole story, and we started from long-term care, as I told you, and a shared responsibility for the whole trajectory, because a lot of money is spent in hospitals to survive, less chances to recover in the post-acute phase. And we talked also about chances to die in the long-term care. And when you tell the whole story, then they feel that they have to be concerned for and take responsibility as society and as government for the whole trajectory. Another thing is we published in journals policymakers read. They don't often read the scientific journals, but we wrote a paper about the medical no man's land after the hospital phase. And that's the whole plan we wrote there, to connect all the trajectories to the chain of care I showed you. And at the last one, we went with the families to our parliament with their stories. It was also published in the newspapers, and with our knowledge and with our research. And I think that makes it strong, the collaboration. But we have a very small country. That's also maybe an advantage, because we know each other and there is a lot of personal commitment.
Yeah. Thank you. Appreciate that. Alexei, how'd you do it in Canada?
It's a good question. I think there's two parts. We can separate let's say the TBI specific related funding that we were able to get for the CTRC, and the initiative and the position paper and the bill C277. I think they're interlinked in some ways. For the interest of our funders to fund TBI research, it's not perfect, but there's been interest in having different programs within the CIHR targeting TBI, which is what we use to create the CTRC. I think it all came from, publicly public cases or victims of TBI that were made the news and were very, let's say, well, the community has been more concerned, and our politicians at some point, which made brain injury and TBI in particular being much more on top of a priority from a funding and healthcare perspective. But that was more than 10 years ago, let's say 10, 15 years ago. And then it probably helped with the most recent initiative. And we can get all the credit of this. I think we were the CTRC, Brain Injury Canada, and our position paper, the catalyst for make it at another level. So there's been patient organization advocating for this, and the whole community was advocating for this recognition for a long time. Because for us, it's a big deal, the way our healthcare system is structured, to have such type of recognition as a chronic condition. So there has been initiative, there has been let's say representation, lobbying from different patient organizations, from our research organizations. And the idea of this bill was there from one MP, but it was an MP from a minority government, so it needed a minority party, so it needed much more, let's say, buy-in from others. So with our position paper, I think we were catalyst there, and because the group is formed of individuals from all across the country, it was disseminated. As Katie mentioned, it's a slow launched, but it really worked. It's not something that's on all newspaper suddenly on one day, but it kind of disseminated everywhere in every cracks of all organization, and everyone was talking about it. And then it really helped push the agenda and help the MPs who was putting the bill. The project. It was a project at the time to go to be able to get his colleagues from other parties to be on board, and making this bill not as a political party bill, but more as a governmental and society idea. And I think that's the key, because in such type of initiative, we have to stay as far as possible from politics. We're going to be with politics, but we need to be more like our interests, our patients, and keep our overarching goal. That's what I think we did. The bill's not passed yet. Okay, you have to remember that. If there's an election tomorrow, the bill will have to go back again to the same process. But we know whoever party is going to be there are going to be supportive. But as in any country, there's always a limit of the number of bills and priority you can have. It's not about it's a great bill. It has to be absolutely the bill to pass, but is it a priority among all other bills? So I don't think it's one initiative. It's an addition of several initiatives, but making sure that all the community is on board. And the fact that we had I think a good strategy of our soft launch, reaching out to the key media and journalists, and those not those that will make it like an event. It wasn't our goal, but those that can have the political strings to make sure the message is very, very credible and will be spread out.
So far, what I'm hearing is, and I'm not being facetious, crash committees, write position statements, and be sure to walk hand in hand with people with lived experience.
Oh, totally. They've been instrumental, Joe, in this process, and Kathy can for sure add on this. Kathy has been an incredible spokesperson, let's say it that way, for our position paper, and she's done so much work, on the ground work, that made that position paper being seen where it needed to be seen.
Yeah, congratulations. Let me turn this question to Dr. Corrigan. Can you talk a little bit about the role of state agencies in promoting access to care? Where do they fit? We've spent a lot of time talking about, the federal government and federal policy, but where do the state agencies come in? What can you tell us about that, John?
Well, the quickest answer, easiest answer to that is in the states, Medicaid and Medicaid policy is all driven by, not all, but largely by a state policy. The program itself is a federal-state partnership. So while mandates do come down, much of what states do are working within the parameters that they are given, and there's a lot of choice. The importance of that is that we know that for many individuals with traumatic brain injury, the event causes financial hardship, loss of job, which in the States, much of your insurance, commercial insurance, is tied to. And so you end up converting from having private insurance to being on Medicaid. Matter of fact, a study a few years ago, showed that traumatic brain injury was one of the conditions that was very quick to cause conversion from commercial to Medicaid funding. Even access to inpatient rehab is a state policy for if you're on Medicaid. While we have seen some positive movement over the years in terms of more states that cover inpatient rehab, it is not a given, and nor has it always been a given. But particularly then when we get out into later services, and particularly for those who need extra supports to not have to live in a nursing facility, that the so-called home and community-based service waivers are policy is largely driven by states. So in the United States play a big role, particularly with those with less resources.
Thanks, John. Maybe I'll ask one or two more questions, and then we'll start taking some of the questions that are coming in from the field. Dr. Beaulieu, so much of your work, I think, really stemmed from the practice-based evidence study that you referred to. So maybe this is a little provocative. So terms of what we learned from that study, what's been implemented? What's changed? That was a really important study. There was a lot of eyes on that, and everybody paid attention to it. What's changed, and your take on the drivers of change or not so much change. Hang on one second. We're not hearing you.
Loaded question.
Try again. There we go.
All right. So yeah, that's a loaded question.
It is a loaded question.
Yeah. So following the conclusion of the practice-based evidence study, all of those studies were put into a special issue of the archives in 2015. And knowing full well that it can take 17 years for practice to change, Jenny Bogner submitted a PCORI grant to specifically target dissemination of those findings and to do additional analyses as well. And so what we did was we created a manual based on the results of the practice-based evidence study. Of course, we had enormous help from all of our therapy teams. A manual was created on how to translate what is technically considered clinic types of activities into more of what we have termed contextualized activity. So basically how to do the same activity, but with greater content complexity in order to challenge the patient. And so we created a manual to do that. The manual went out to sites. We created a social media blitz, basically, to demonstrate how the difference between the different types of activities. And now that we're in year 4 of the Care for TBI study, I can tell you that it's had minimal impact. And so what I think we need to do is with every finding that we find that's of significance, there needs to be a follow-up of what is now being called implementation and dissemination. So strategies literally designed to implement findings and not just assume that education, presentation, and dissemination is sufficient to get the practice to change. You actually have to develop strategies to get that into place.
Took my bait perfectly. Thank you. Let me turn to, in my last question, to Miriam and Enrico. Tough question. What is the one thing you didn't have during the early phase of your journeys that would have made the most difference in recovery if you had it? All right, Miriam's already ready to go. You have to come off mute.
I didn't know I was going to get called on, so I have a cat. The thing is actually what Dr. Finn said, which was he called it a care coordinator. And that's still what I wish I had in this phase. Just someone who could look at all these different pieces and quarterback it. I think, Dr. Giacino, when I saw you at another TBI related event, oh, no, it was Ross Safant who asked me, who's your point guard? I'm not a sports person. I don't really know sports metaphors, but I don't have, and I haven't had, and I still don't have someone who can take the myriad pieces and help me organize them, prioritize them, sequence them. That's what I wish I had at the beginning, and it's what I wish I still had.
And it is what we have today for cardiac care, for respiratory care, for cancer care. We don't have it for brain injury. Thanks, Miriam. Enrico, looking back.
I can say pretty with confidence, without a doubt, that the single most positive and influential aspect of my long-term recovery was without a doubt my excessive participation in cardiorespiratory endurance sports and whatnot. And I think that if I had had access to more active care, or dynamic care, or certainly more active care with regard to my exercising, and I think I could have reaped even more benefits at point in my recovery than I did in the long term.
Can I add one thing, which is just that I was in the incredibly fortunate position of being able to leave my job, of being educated, of being unafraid to ask questions, as I'm sure Dr. Manley and Hempel and others who met me on this journey would attest. I thought every day, and I shudder to think what would happen to the child of someone who didn't have those privileges. You know, if English wasn't my first language, if I didn't have the education that I do, if I would have been more intimidated by the expertise of people around me. So the inequities in outcomes are just staggering, and it breaks my heart to think about that. So that's the other thing I would say, that people really need an advocate in the system.
Thanks, Miriam. Thanks, Enrico. So there are a couple of questions I think have this theme underneath. And it's a question about, I'm assuming that it's coming from a rehabilitation therapist, because the question is about how rehab therapists can assist with these advocacy efforts that we've talked about today. I certainly have thoughts about that, but let me turn to panel first. All right, I'll start us off. I think one of the most important things to do is to sort of do a local assessment of where you stand, and then have a look at whether there are some practice guidelines that are evidence-based that can inform what care is being provided in your local institution, on your unit, and then do an assessment and ask whether you are aligned with best practices. And then if the assessment is that you're not, or not as much as you want, that's worth bringing up to your colleagues, that, multidisciplinary colleagues who are, rehab is a multidisciplinary field. So we don't do anything in isolation. It's different in that regard. Our health system is reorganizing as we speak, and rehab is reorganizing and will be reorganized in a different way, because we cut across everything. So we won't be our own entity, like neurology and neurosurgery and critical care. So I think one thing to do is to engage the conversation, starting in your local community. We've done some of that at our place by establishing local guidelines for care with people with severe brain injury and those with disorders of consciousness. So we've developed protocols that we ask everybody to use. We need to do the implementation studies, of course, now to see, are they, do we have compliance and are they working? But that's a first step. The second thing, and Claude, please say more about this, get engaged with some of these efforts that are national, like what the Curing Coma Campaign is doing. There's a clear contingency of therapists involved in that. Claude, do you want to say a few more words?
Well, I guess I would just say that one of the things that we are trying to do is, and I mentioned it in the talk a little bit, is to create a community that's accessible to those who may not be either scientific experts, or it may not even be their primary or only passion, but that by in our own hospital, when we create our World Coma Day shout out, people come out of the patient care rooms and we'll hold up a sign that says, I'm curing coma, or something like that. And it's a way to just engage informal participation and create a little bit of a vibe locally and nationally. Obviously, there's more to that, and there are numerous opportunities through groups that have been discussed here and the Curing Coma Campaign to go deeper. But we'd like to have a very, very broad base of just expectation of, and that sort of goes to maybe a little bit of the culture change aspect.
Thanks, Claude. There's a question that asks, where can the list of TBI research topics needing to be addressed be found? I think a great start is, in fact, the NASM report that Dr. Berwick talked about and Dr. Manley talked about. It is a very detailed discussion of what the clinical needs are and what the research needs are today, and then lays out how they might, or begins to lay out how they may be addressed. And as Dr. Manley's talk spelled out, what are the actions that are underway as we speak. But I think it's a good source to really get your head around what the needs are, both in terms of clinical practice and in research. You can, I think you can just simply Google TBI Roadmap Report, and it should get you to where you need to be. It's a freely accessible document. Okay. There are some questions that are just thanking speakers for provided. Let me just ask the panel here if anyone has other comments to add any part of the discussion today. I think, keep in mind that this summit is a stage setter for the future work. And again, we're going to talk a little bit about the next step in a few minutes, but that's why we're here, to lay out the state of the science. What are the problems? What has worked as seeds for further discussion. Any other just open comments? Okay, Dr. Finns, I think has to. Oh, you have a mic.
I have a mic, but I'm off camera. But a question for John Corrigan, if he's there, right? Oh, John, loved your talk. Towards the end, you were talking about all the costs associated with people who eventually were accepted to rehab, but were still in hospital, and those who were rejected from rehab, but had to remain in hospital before that determination was made. How much money has been spent? You mentioned days. How much money does that amount to? And is there any way to accelerate the process and redirect those funds to rehab for folks who need rehabilitation? Has anybody done an analysis of that?
Well, certainly out front on this issue has been AMRPA. They have done some of the initial surveying that got the interest of policymakers. They were the push behind several governmental reports. I don't know in my head the average cost of an inpatient day on a trauma unit, but I am guessing it's not it's not a small number. But of course, part of our fragmented system, as opposed to what Michael talked about, is that that cost is being borne by an acute hospital. That acute hospital may or may not have an inpatient rehab facility. Many do. So maybe there is a way internally to benefit from the cost offset. But in the end, you're not going to do well going against the tide, going against the practices of the Medicare Advantage plan. So I really think it's an area that needs federal regulation, and it's only getting worse because more and more of the Medicare population are being covered by Advantage plans versus straight fee-for-service Medicare.
It just seems like a whole bunch of money that's being wasted.
Absolutely.
And could be used in a better way. I have a related question, Joe. You also were talking about social context at the end, about who gets rehabilitation, and it reminded me of much of the discussion about hospice benefits. And I don't want to conflate hospice with this population, but one of the tropes in palliative care is that you're okay if you're male, you're young, you're older than your spouse, and your spouse is female, and you have a house, and then you can get the home benefit. If you're an older woman and you don't have a spouse to take care of you and you're undomiciled, you're basically unable to get, hospice benefit because most of it occurs at home. And I'm just thinking in a kind of a legislative sort of omnibus kind of way, we might be able to fix the rehab problem and the hospice problem with some kind of, policy initiative that handled both of those problems, recognizing that, as you said, the context really matters. Do you have any thoughts on that?
Me again, Joe. So, I don't. Just requiring a house, introduces a social determinant of health. So, can I get that? How far would we go in a healthcare system to invest in the home to make it make it a place where care could be given for somebody who has more than average medical acuity. COVID taught us that we could go further than we thought we could. The hospital at home programs really caught on during COVID and seemed to have some momentum after. But once again, are a lot cheaper than but once again, I think as we do this, we have to keep an eye on who we're leaving out when we create these new programs.
Let me pose a question to Dr. Hammond. We heard very loud and clear from Miriam, and it's been alluded to before about the importance of a care navigator. Dr. Hammond, you are co-leading a study called Be Healthy. That is a topic. I believe that's been discussed in that grant. What have we learned about? I'll be more specific. A review was done, right, from looking at how care navigation works, how is it effective, and the idea being, would it work for traumatic brain injury? Any takeaways at this point from that project, or is it sort of too
early? So it's been an important part of our design of Be Healthy because of this feedback and what we know from clinical care of people with TBI. We don't have results specifically from Be Healthy of any of our pilot projects yet, but we do have in place across the state, across the United States, several states that are state partnership have state partnership grants from ACL, and what Be Healthy has done in combination with NASHA is looked at what those programs look like across the United States in regards to providing resource facilitation, what types of resource facilitation are being provided, and what kind of assessments they're doing. So largely NASHA has pulled a lot of that data together, and I'm going to point to John for further comments because I know he also is super involved both in Be Healthy and resource facilitation.
Yeah, so I would say, well, we don't have the evidence yet, but I think as we have looked at other models, we've looked at what's happening in states, as Flora mentioned, that in addition to just medical expertise, and it's not just multidisciplinary but interdisciplinary medical expertise that's needed, it has to also include a recognition of the importance of the person and a person-centered approach, their engagement in their own treatment and to whatever extent possible as assisted, and from that their self-management to the extent they can. And we simply will not be able to afford a system where we are doing for everybody, and we don't need to, and people don't want to anyway, so they don't want to be done for. They'd rather do it themselves. So it's just not medical expertise. A system of care for that's addressing chronic brain injury is going to have to be a partnership with the individual and their family where that exists, and optimize the engagement and self-management to really have its biggest impact.
Maybe I'll introduce one more question and then we'll, oh, Kathy, please.
Sorry. Yes, thanks, Joe. I just wondered if I could get your opinions. Some of you perhaps might be more inclined to answer this question than others, but with the recent election of Donald Trump and the accompanying changes I think we can expect in leadership and policy priorities, how do you anticipate this administration might impact TBI rehab research funding in the US? I asked that question specifically about the US, but additionally, given these shifts, I'm wondering if you believe we need to adjust our approach within the World Health Assembly Resolution Coalition to maintain alignment with US priorities or effectively advocate for global support differently, if anyone's prepared to answer this concern.
I think we should move to the next question.
Yeah. I'll tell you, in Canada, we talk politics far more openly than I see in the US, and I understand.
Rather talk about sex, Catherine.
Yeah, John, you are fun. You know what? That's why you're on the coalition. Leave it at that. We can do something on offline after, but it is major.
I'll offer one comment. Dr. Manley's not on the call anymore, but and this is second or third hand information, but he mentioned that I think there was a recent meeting between the people from NASEM, from the National Academy of Science, Engineering, and Medicine, and it was a apparently tough meeting, but the word is, what came out is that the one thing that there was clear interest in was, interestingly, traumatic brain injury. Well, other things were hammered pretty hard. This was something that wasn't. So it may be that maybe other challenges, that TBI is not one of them.
In his prior presidency, I do recall there was a fund set aside for TBI. And it's vague right now, but it seemed to have been a priority. So I don't want to upset anyone. I really just, there's a little note of optimism. So.
Yeah, I think we need to stay optimistic.
Yes.
Let me just, Dr. Deutsch, if you're available to come on. You have provided consultation to CMS. You have been involved in drafting some of the reports to CMS, et cetera. If you were to offer, a word of wisdom to the group that's going to attempt to move this initiative forward, to try to remove some of these barriers that are around health service delivery, what would that word of wisdom be?
Yeah, I'm not sure I have anything specific, but I think, you've pulled together a great session today to provide some evidence and some experience from different countries. I think that's really, really important. As I said in my presentation, not every IRF is probably capable of providing the expertise for people that we're talking about. And so I think taking that into consideration, I think is an important issue as you kind of think forward.